prevent all cancer cases, but nobody stood to get rich from it, would we still think we could do it, or we should do it? And I have good news about that and also bad news. And I'll start with the good news. The good news is that up to 2/3 of all cancer cases are caused by exposures that we can prevent. This figure comes from the US President's Cancer Panel, and it's actually conservative. A study conducted by researchers at the National Institutes of Health puts this figure even higher. They say that 90 to 95% of cancer cases are caused by preventable factors. One theory of cancer risk that I find really helpful is the causal pie model. And this idea comes from epidemiology. This model says that we all have our own unique pie chart for cancer risk. So it might include things like genetic risk factors, exposure to cigarette smoke, exposure to pesticides, and exposure to pollution. And everyone's pie chart is unique with a unique mix of factors. But if any single risk factor goes missing, then cancer won't develop in that person. And that would mean that if we can remove even one of the risk factors that's common in a lot of people's pies, we could prevent many, many cases of cancer, which is a really exciting idea to me, at least. But the bad news is that all of our market incentives are pushing us to continue focusing almost solely on treatments for cancer rather than prevention. This chart is from a market research company that serves investors. And as you can see, the global oncology market was valued at $286 billion in 2021 and is expected to reach over $581 billion by 2030. And this box on the left is from the same webpage. And I've highlighted the part where they're citing the fact that cancer cases are expected to rise by 47% from 2020 to 2040 as evidence of strong growth for the market. Which is a little bit unsettling. And unfortunately, there's no similar market projection for cancer prevention. So these are some of the reasons I wrote my book. But like most people, and probably many of you who are here today, I've also had my own personal experiences with cancer that made me want to look into this issue more. In 2011, my younger sister, Abby, was diagnosed with thyroid cancer when she was 25 years old, which is very young for a cancer diagnosis. And thyroid cancer usually runs in families, but no one else in my family had ever had it. No one else has had it since. So we were left wondering whether something in the environment could have played a role. I'm also an investigative reporter. And so in 2019, still thinking about those questions, I wrote a 5-part series on cancer and environmental exposures in Pittsburgh and Western Pennsylvania, which is where my sister and I both live, titled Prescription for Prevention. And these were some of the headlines from that series. The series won a couple of local journalism awards, and I got a nice note from a publisher congratulating me and asking if I'd be interested in expanding these ideas into a book with a more national focus. And six short years later, this is that book. Just a little more about me. I've been a reporter for environmental health news since 2018. And before that, I freelanced covering a wide range of issues, including the environment and social justice for a whole bunch of media outlets. I've gotten some awards for my reporting specifically on environmental health. And I live in Pittsburgh with my husband, Michael, and our dog, Mochi, who is digging the rug behind me. So apologies if you can hear her. I do usually show a picture of her because she's a very good dog, and this is a heavy topic, so it's nice to have a puppy break when you can. My sister made a full recovery from her thyroid cancer. She had her thyroid removed and has been in remission for more than a decade, and this is her 2 Christmases ago now with her husband and her 2 cute kids and their goofy golden doodle in his pajamas, who is also a good dog. So some of the things that I learned while I was reporting on environmental exposures and cancer were really shocking to me. And the first was that since we started tracking cancer incidence in the 1970s, rates of childhood cancer have been steadily increasing. This chart is for the United States, but this trend is also mirrored at the global level. And today, cancer is the leading cause of death by disease for children in the United States. From 1975 to 2019, incidence of childhood leukemia, which is the most common type of childhood cancer, increased by 35%. And incidence of childhood brain cancer, another common type of childhood cancer, increased by 33%. Nationally, 1 in every 285 American children is now diagnosed with cancer before age 20. We've seen a similar increase, although a much more sizable increase, in fact, in certain adult cancers that are linked to environmental exposures, including multiple myeloma, non-Hodgkin lymphoma, and testicular cancer. And as you can see, these are pretty substantial increases during that time period. That 76% increase for non-Hodgkin lymphoma is particularly shocking, I think. And when I was reporting that series on cancer and the environment back in 2019, I interviewed a really smart epidemiologist and pediatrician, Dr. Phil Landrigan, who ended up writing the foreword to my book. He said something that was a total light bulb moment for me. He said, this increase is too fast to be due to genetic changes, and that our basic diagnostic tools for cancers like childhood leukemia are the same now as they were back in the 70s. So this also isn't a matter of just diagnosing more of something that's always been there. And that means that this is a real rapid increase in childhood cancer rates. And the only other possible explanation is environmental factors, which includes anything outside of our own bodies and DNA. So that includes things like smoking and diet, as well as exposure to cancer-causing chemicals and pollution in our environment. But Dr. Landrigan also pointed out that those lifestyle factors might play a significant role for adults, but in general, kids are not engaging in harmful lifestyle behaviors like smoking and drinking. This picture is kind of funny because we assume it's a joke, although it was 1955, so who knows. But for the most part, kids are not smoking or drinking. Their parents might do those things, but over time, the percentage of parents who smoke and drink during pregnancy has declined, while childhood cancers have continued to increase. And one thing that has increased over the same time period is the number of chemicals that kids and all the rest of us are exposed to on a daily basis. Since the start of the early 20th century, more than 300,000 new chemicals have been invented, and these are brand new materials that didn't exist before. They're manufactured in enormous quantities, and global production is on track to double by 2030. Some of them are really helpful and have improved our lives, but most of them have never been tested for safety. And among those that have been tested, even the ones that we find out are harmful tend to stay on the market, including many that we know are carcinogens. And in the last 50 years, only 5 chemicals have been removed from US markets because they're harmful. So the World Health Organization has determined that more than 100 manufactured chemicals can cause cancer in humans. And these are some of the places we come into contact with these chemicals. So this list is not comprehensive, and it includes some things that are suspected carcinogens. And many other chemicals we come into contact with regularly are known endocrine disruptors, which disrupt our natural hormonal processes and contribute to things like obesity and neurodevelopmental problems. And evidence increasingly suggests that endocrine disrupting chemicals may also play a role in the development of hormone-related cancers like prostate cancer and breast cancer. This list doesn't include chemicals that cause other non-cancer health harms, of which there are many. And again, there are many more chemicals we come into contact with on a regular basis that just haven't been tested for safety, so we don't know. I also want to talk just briefly about how our war on cancer is going so far. So we're much better. We're 50 years in on this war, more than 50 years in now. And we're much better than we used to be at treating cancer, but we're also getting a lot more of it. So 1 in every 3 Americans can now expect to get a cancer diagnosis at some point in their lifetimes. And just because we're better at treatments doesn't mean we've solved the problem. More than 1,000 Americans still die from cancer every day. And treatment is difficult. Therapies like chemo can have side effects that last for a lifetime, and survivors live with fear that their disease might come back, and anxiety and deja vu every time they have to go in for a follow-up scan. That's something I've seen in my sister. So the bar cannot be, it's okay to get cancer because we know how to treat it now. And the main reason we're not successfully preventing cancer is that we're not funding prevention. Globally, just 7 to 9% of all cancer funding goes toward prevention. And personally, I'm a pacifist, but if we stick with that war metaphor that we've committed to, and we use the more generous estimate of 9%, that would be like spending 91% of our war budget on treating soldiers who come back from the battlefield wounded and just 9% on offensive and defensive measures that could prevent people from getting hurt in the first place. So I think it's time for a new strategy that includes an offensive war against cancer in the form of prevention. Right now, the tiny bit of funding that does go toward prevention primarily focuses on lifestyle choices like not smoking and diet and exercise. And those things are really important and they matter. They're worth prioritizing for lots of reasons beyond just our cancer risk. But as we've learned, they're also not the only things that are influencing our cancer risk. And sometimes people can feel empowered by focusing on the things that are inside their individual ability to control. But that's also a lot of responsibility and it can feel really overwhelming. And when I was working on the book, I talked with one oncologist, Dr. Margaret Kripke, who actually served on the president's cancer panel when it did its initial report on environmental contributors to cancer. And she shared a story about meeting a young man who'd made all the healthy choices. He was like a long distance runner. He ate super clean. He'd never smoked. And he was confused and then furious when he got diagnosed with cancer. And he felt he'd been led to believe this was something he could entirely control through those lifestyle choices. So he felt like he had been lied to. And a better alternative would be encouraging people to make healthy lifestyle choices, but also acknowledging that there are numerous factors beyond our individual control that increase our cancer risk, and then empowering people to advocate for a healthier world by teaching them how to push for systemic change. So that's what I tried to tackle in my book. I think that learning about all of this can feel really overwhelming and scary, and it definitely did for me at first. And at first glance, it can seem like there are only two options. First, to become totally obsessed with this and learn everything there is to learn and strive to become an enlightened organic goddess who never eats a conventionally grown vegetable, or two, to throw up your hands because it's just too overwhelming and everything causes cancer nowadays. So let's just try not to think about this too much. But the exciting third option in infomercial parlance is collective action to try and reduce these sources of exposure in our lives and go on the offensive against cancer. So there are lots of different types of people with different strengths that can help play a role in this movement. And I'm going to talk very briefly about three broad categories here. Before I jump into those, I do like to take a quick moment to offer some comfort to anyone who's stuck plotting out how to become an organic goddess or feeling like the dog in the burning house. There are lots of things you can do on an individual level, and I think we're going to talk more about those later in this webinar. I also usually share some resources that are listed here, like the EWG Healthy Living app, the Healthy Building Network. There's a lot of these resources in my book if you're looking for a longer list. But a lot of people don't have the time or money to do all of that. And one thing I heard over and over again from the people I profiled in my book is that we can't shop our way out of this. This problem is too big. And so it's important that while we do take steps to protect ourselves and our families through our individual choices, we also prioritize pushing for systemic change. So number one is supporting cancer prevention initiatives that are specifically aimed at reducing our exposure to harmful chemicals. And one easy way to do this is donating time or money to organizations leading this work. There's a short list here. There's a much longer list in the appendix of my book. Two is pushing for better chemical regulations. An important part of that is signing up for notifications about relevant legislation. A lot of those groups I suggested, if you follow them on social media or get their newsletters, you can also like sign a petition in a timely way or reach out to lawmakers when it's timely. And three is applying market pressure. You can amplify the impact of your individual choices a lot by taking a few minutes to tell both companies why you switched products. If you have investments, including retirement accounts, you can also leverage those to increase market pressure on an even larger scale. I'm exactly at time, actually. So I like to close with this quote by the cultural anthropologist Margaret Mead, because it always makes me feel ready to fight, and invite you all to read my book and learn more about how to join this movement. Thank you. And with that, I'll pass it. Am I passing back to Emily? I think so.
Thank you so much, Kristina. That was really fantastic. So I'm going to do a little bridge into Dr. Criswell, and we're going to just reiterate a couple of the things that you were hitting there, Kristina. Just a moment while I get this sharing. There we go. So one of the things, so obviously this webinar is being hosted by Defend Our Health in partnership with Island Press. And so first of all, this is going to be a great book. I really encourage everybody who is here to give it a read. We will be sending you a secret discount code after the session, along with a recording of this. But Defend Our Health is one of the organizations that is working to organize action around this. And we have been focusing on PFAS and several of the other toxics that Kristina just mentioned, and how to break that cycle of exposure. So Kristina just did a great job of kind of explaining the individual versus system level exposure changes that we can do. So when we're talking about PFAS, those per and polyfluoroalkyl substances, you have probably heard a lot about them in the news. They are those nasty forever chemicals that are in nonstick pans. They're in waterproof coats. They are used in a whole bunch of industrial applications to just make things grease-proof or water-resistant or a little bit more slippy-slidey. They put them into dental floss to make it nice and easy gliding through your teeth. And the biggest issue which we have with PFAS and a lot of these other toxic exposures is that the cancer research that tells us that these are carcinogenic lags the exposure by years and decades. So the two of the big PFAS chemicals that have now been phased out in the US, PFOA and PFOS, they have been classified as like definitely there is strong evidence these are carcinogenic. One, PFOA has been classified as carcinogenic to humans, which means there's strong evidence that cancer is being caused by these chemicals in people. The second one, PFOS, has been classified as possibly carcinogenic to humans, which is a very researchy way of saying there is very strong evidence that this is causing cancer. It's just that the studies that it is causing cancer in are animal studies. So we have these two particular PFAS chemicals, which we know are causing cancer, and they have now had that regulatory practice step taken where they are not being used in the US anymore, although they are still being used in some other countries. And we do have legacy exposures happening. But this larger group of chemicals is continuing to be produced and is continuing to be put into our products and into our food supply and into industrial applications and spilled into our communities. And so when we are looking at how we can take this system level action to stop harms from happening and to stop these cancers from occurring, one of the system level approaches that we really need to be taking is putting in place a hazard-based or precautionary regulatory structure and implementing the move to ban chemicals where there is evidence of harm at a class level. So one of the things that Defend has been leading the nation in has been pushing for PFAS to be regulated and phased out as a class of chemicals rather than going after a single version of PFAS, the next version of PFAS, and allowing industry to continually have this treadmill of replacement toxic chemicals as the evidence of harm emerges on the first. They replace it with a very similar but not yet regulated second chemical. And this is how they've been experimenting on all of our communities for decades. With PFAS, it is happening with a lot of the plastics related chemicals. There were several of them, Kristina, on the slide that you were showing, especially in cosmetics. We're having food supply contamination. So the biggest issue with our current approach to chemical policy and to protecting ourselves is that the research we are doing is lagging so far after the exposures that are happening, because cancer takes decades to develop potentially, or years for children's cancers. And so we really need to stop those exposures from happening to be able to effectively prevent these disease outcomes from occurring. So what are the exposure pathways specifically for PFAS? There's going to be a lot of overlap with PFAS. We're using it as a kind of just a case study, but a lot of the toxic exposures that can trigger these cancers from develop are following very similar pathways. So we have AFFF is a specific PFAS exposure that is advanced firefighting foam. So they put this great chemical from the 50s and the 60s into firefighting foam, and they sprayed it all over. They did firefighting testing. They used it when they were fighting fires at airports or other places. They spilled it, as they recently did in Brunswick, Maine, and it contaminates local waterways, local soils. The actual firefighters are heavily exposed, and this PFAS then builds up in the blood of people who've been exposed and can cause health outcomes that Dr. Criswell will talk about. We have industrial releases. This stuff is being manufactured. It's spilled during manufacture, or it's sprayed on things and it washes off as a coating, or it's released to air. And these industrial releases can especially harm fence line communities that are near production facilities. And then everyone in the population is also directly exposed to a lot of these toxic chemicals, including PFAS, via household products like those nonstick pans I mentioned, like that nice slippy slidey dental floss, like the waterproof coating on the rain jacket that you got. All of these other sources can also, they contaminate our drinking water sources. So if you're getting your drinking water from wells or a public water supply, I believe that the US Geological Service recently had a study out that over 200 million Americans' drinking water is potentially impacted by PFAS exposure. That is not an individual action step in terms of where we want to efficiently be putting those resources. So if we want to invest in prevention, do we want to invest in prevention that is individual, or do we want to do this system level approach to really address these exposures? Two other places where PFAS exposure is happening is because there's PFAS in all of these other places, it's in our bodies, it's in our household water that we're washing down the sink, it ends up in our wastewater. And so then it's concentrated at a wastewater treatment facility, ends up in the effluent, which is the liquid coming out of a wastewater treatment plant, and the sludge, which is the solids. The effluent usually gets released into local rivers after being treated for things like bacterial contamination, but PFAS has not been part of the effluent standards for treating that before putting effluent into rivers. So our rivers are then being recontaminated by concentrated PFAS from all of these other sources. The sludge application from these wastewater facilities has been a major source of contamination to our food supply. Why? Because we are taking sludge from wastewater facilities, applying it to farms as fertilizer. And then the PFAS in that sludge is coming into the water. It's coming into the food that the cows and chickens are eating. It's coming into our crops that we're growing. So our food supply across the country is actually pretty significantly contaminated as well by PFAS. And all of these exposure pathways kind of end up in a loop, because then you eat food or drink water that has been contaminated. Your body becomes contaminated, and then you go to the restroom and it goes back into the wastewater side. So we have this really pervasive exposure pathway that is happening, where these chemicals we know some of them are very toxic. We have evidence that others are very chemically similar and likely to have similar impacts, but the research has not happened yet because they're brand new versions of these chemicals. And we have this ongoing exposure issue that is happening across the country to these toxic, they are called forever chemicals because they don't break down. So we just keep adding more and becoming more and more exposed to these. And then we start having these really devastating health outcomes. So Kristina already talked a little bit about the individual versus the community level and system level approaches that we can take to address this. I'm just going to reinforce that individual actions, they are possible for some of us to somewhat limit our exposure, but they are very unequal in terms of where the burden ends up, because to take individual action means you need to have the time, the money, and the knowledge to be able to do this. So all of these steps, testing and treating your household water supply, researching products and changing purchasing practices, avoiding foods like fish that you could catch from highly contaminated rivers, replacing existing household products like your PFAS-coated pans or your PFAS-coated clothing or couches, and changing jobs if you have a really high workplace exposure. Those are all things that require a lot of resources to be able to do. So some people are able to pursue some of those individual actions to reduce their individual exposure and their family's exposure, but it will not fully eliminate their exposures. And many Americans cannot do that. And so then we have health disparities that mirror a lot of the other social and economic injustices and disparities that we see across our communities. what are those population and community actions that we can take? We can set, when we were talking about policies that we can move towards, we can set drinking water standards and provide resources for testing and treating for all families, doing it at the population level, making sure that there are programs in place for people who are on things like well water, where you can't access public drinking water systems for testing and treatment. We need to make sure that we have comprehensive programs in place to cover everyone so everyone can have safe drinking water. We need to stop PFAS contaminated sludge from being spread on farms so we stop having a new source of continuing contamination to our farms and our food supplies. We have to phase out PFAS and other toxics from products and equipment that we use in our homes, that we use in our communities, heating, ventilation, and air conditioning units. Many of them have PFAS in them and leak into our homes and our communities. There are PFAS-free alternatives that work very well, but we need to have regulatory or public pressure to move towards those solutions. We need to support farmers who are dealing with existing contamination of farms, because there's really important research that's happening, especially in Maine, to help farmers economically continue forward with a farm while making sure that their families and their farm workers are safe and that they are having less PFAS going into the food products that they are selling. And we need to provide medical monitoring and intervention for patients and folks who are more heavily exposed to these chemicals as we work to really break this chain of exposure and infection, essentially. It's not infectious, but it needs to be treated as a contagious disease to a certain extent. So all of this kind of comes together to we have to take these community actions together, but we also need to make sure that patients and community members who have been exposed to this can take action to protect themselves and reduce the harm and identify where that harm is coming from. So with that, I'm going to hand you over to Dr. Rachel Criswell, who is a physician based in Maine who has been doing intensive research around PFAS exposures to help improve clinical practice and patient care. I'm going to figure out how to stop sharing so that you can take over, Dr. Criswell.
Thank you so much, Emily, and thank you so much, Kristina, for that wonderful talk. My name is Dr. Rachel Criswell. I'm a family medicine physician based in Skowhegan, Maine, which is a small town between Augusta and Bangor, so the central part of the state. I want to emphasize I'm a primary care doctor first, and I have sort of stumbled into a research career on clinical care for people who are affected by PFAS, and how to sort of holistically approach this issue of PFAS contamination in a way to improve the health of our local population and then also my patients in particular. So the first thing that I want to just explain to everyone and underscore from what everyone else has said is that we're all exposed to PFAS and a number of chemicals on a daily basis. So this isn't to take the dog in the fire approach that Kristina mentioned, but this is something that's just a part of our world and a part of being a member of our civilization. One thing that I think is really exciting is that these sort of national legislative changes really do make a difference. In this graph here, you can see that the phasing out of PFOS and PFOA, which occurred in the early 2000s, has resulted in an overall decrease in all of our exposure to PFOS and PFOA. So these large scale actions in public health really do make a difference. That said, we still have all of these new chemicals coming out, and chemical companies are certainly developing replacements that have unknown health effects that are coming out in the market every day. Because of where I work, I tend to deal with folks who have what we call high exposure to PFAS. So these are folks who are in those categories that Emily mentioned, people who work in industry where PFAS is used, people who are firefighters, people who live or work on military bases. And in my case, I work in a community where there's a lot of former agricultural land that's been applied with contaminated sludge or biosolids. And so some of the folks in my community, in addition to having their farms shut down and their wells contaminated with PFAS, have found that they've had hundreds and thousands of parts per billion in their blood of PFAS. So these are exposures much, much higher than what we're all exposed to on a daily basis. I'm going to walk you through the slide, so just sit tight. One of the things that, Kristina presented that I really liked was this idea of the causal pie. And something I really try to clarify with my patients is that PFAS toxicity or PFAS poisoning is really rare. And so likely PFAS is not causing your headache or dizziness or, back pain or something like that. But PFAS is one of those slices to the causal pie. And so it might be the risk factor that like tips you over into developing a health outcome. Um, One of the really cool things that's happened in the PFAS world in the last couple of years is that in 2022, the National Academies of Science, which is a federal organization, did a review of all of the literature on PFAS. And this includes epidemiologic studies, like studies of large groups of people where they looked at exposure and health outcomes. It involves studies on animals, it involves studies in labs, and they were able to take all of this information, which has been out there but kind of not consolidated, and consolidate it into a report, 300-page report, that really for the first time gives us some grounding in the idea that exposure to PFAS is a risk factor for other diseases and what we can do about that. So, like I said, the things that came out of the NASEM report that I really appreciate is that they named a number of health outcomes that they find that there is sufficient evidence in the research showing that PFAS is a risk factor for these things. And then they looked at a bunch of other health outcomes that they're using the term limited evidence. I like to think of it as evolving evidence because peer-reviewed science does take a little while. It's not that they found things that were against this association. It's just not quite enough yet. So they classified a bunch of things as having limited evidence of being associated with PFAS. Since we're talking about cancer here, there is a pretty strong evidence of an association between exposure to elevated levels of PFAS and kidney cancer in adults. And there's evolving evidence, because PFAS is an endocrine disruptor, of associations between high levels of PFAS exposure and increased risk of breast and testicular cancer, as well as thyroid disease. This is a rapidly evolving field. And so if you were to go to a conference on PFAS science, you would find that there's lots and lots of other health outcomes that are being looked into, cancer outcomes and otherwise. One of the things that's great for me as a primary care physician is that the NASEM report took all of this epi and basic science research and put it into clinical guidelines that I can use in my clinic. And I just want to reiterate that I'm a primary care doctor. I don't have any extra training in environmental health. And this is very easy to implement in my clinic. You don't have to be at an Ivy League institution in order to implement this on a daily basis. So the National Academies looked at 7 what we call legacy PFAS. These are old PFAS that we're still exposed to in our water system and food system. If you check these in blood and add them all up together, they were able to say that if you have a level less than 2 for that sum of 7, you probably are not going to have this as a risk factor. If you have a level between 2 and 20, which is about 89% of the American population, you possibly may have PFAS as a risk factor for health effects. And if you have things over a sum of 7 over 20, then you are very likely to have an increased risk of these adverse health effects from PFAS exposure. And again, unfortunately, some of the folks that I'm working with here who've been exposed via farmland are dealing with levels in the hundreds and thousands. So what can we do in a primary care setting? One of the things that I've started implementing in my clinic, in my physical exams, is to screen and test people who are at risk of high exposure. So as a part of my annual physicals, I ask people if they've ever been a firefighter, if they've ever been in the military, if they've ever worked in an industry with fluorochemicals. And then there's this sort of lovely vague area where they say people living in areas with known PFAS contamination or near PFAS contamination are also candidates for blood testing. And there's some recent studies, including some that I've been a part of, that show that this is legit. There are people who don't have an identifiable source like water or an occupational source who still have elevated levels, and our understanding of the exposure science is still evolving. So if someone screens positive for one of these things, I usually talk to them about what PFAS is, how it's a risk factor similar to smoking or genetics, and what we would do if we were to test and find that their blood was high in PFAS or low in PFAS. There's a number of ways to assess blood levels, and part of the research that I've been involved in recently is sort of looking at whether we need to go through with blood testing or whether we can sort of estimate an exposure. There's some hospital-based laboratories or laboratories you can access through the hospital that have very reliable blood testing that's becoming more and more affordable, although still can be sort of cost prohibitive based on insurance coverage. And then there's some at-home tests through companies like Eurofins and Quest Diagnostics that can give you an idea of your PFAS exposure. There's also some online models that will look at the levels of PFAS in your water and estimate what's in your blood. This can be effective as sort of like a first pass, especially if you're on public drinking water that's regularly measured for something like PFAS. But some other recent evidence has sort of shown that blood testing is really the best way to assess human exposure. And again, the NASEM report gave this handy little guidance for primary care clinicians everywhere that says that if you fall under this 2 nanograms per milliliter for the sum of 7 PFAS, you just continue on with your normal health care. If you fall between 2 and 20, and again, this is 89% of Americans, the recommendation is to adhere strictly to our preventive care standards. And so this may seem like it's uh, a minor thing, but for a lot of the folks that I work with and a lot of the people in the high exposure risk category for PFAS, this could mean the difference between having a primary care doctor and not. So think about, firefighters, farmers, people who are usually young and healthy or often young and healthy and not accessing care. Knowing that they're in this 2 to 20 level might get them in for their annual mammogram or what have you. And for folks who are over 20 nanograms per milliliter, the National Academies recommends additional screening every year along in your normal physical. And what I'll say is none of this is rocket science. This is stuff that I would order on a regular basis for many folks based on symptoms. And so it's stuff that as a primary care doctor, I can easily order. It's not prohibitively expensive and I can easily interpret. One of the things about environmental exposures and cancer outcomes or health outcomes is that often the treatment for the disease is the same as if it was not caused by environmental factors. So I'm not doing like PFAS chelation or anything like that. I'm just treating a thyroid disorder or referring to a urologist for kidney cancer. This area is more than just an algorithm to follow, though. I think the algorithm gives us a really good basis, but I think that there's a lot of room for broadening our minds about environmental exposures and including them into our differentials, as Kristina mentions. So these are a couple of publications that I've been lucky to be a part of recently, sort of exploring the idea that environmental exposures and taking an environmental history, especially in certain circumstances, is a really important way for us to better guide diagnosis and prevention and treatment for our patients. So, for example, if I have a patient who's experiencing bloody stool, usually there's a certain for like John Doe or Jane Doe, there's like a certain pathway of diagnosis that I would follow. But if I know someone has also been exposed to PFAS, I know they're at higher risk for ulcerative colitis, which is an immunological disorder of the gut. So I might have that in my mind as well. And I think one of the things that's so exciting about thinking this way and thinking in a holistic way is that I'm able to work with patients to take the research that I'm doing and that others are doing and put it right into my clinic. So one of the reasons that we did this study on looking at blood testing and toxicokinetic modeling is because we didn't know if if the blood tests were accurate and if we needed to put people through blood testing to assess assess their exposures. I've been rolling out this medical monitoring for PFAS in my clinic on a daily basis, and as I'm going, finding little ways that I need to tweak it and change it, and talking to other doctors and researchers about how I need to do that. One of the things that my colleagues and I saw was that people are experiencing significant stress from this chemical contamination, and so we designed a research study to better support our community and figure out how to support that. Another thing that we're sort of exploring based on recent research is body burden reduction of these chemicals. How do we get them out of our body, which is a new and evolving field. But what I'll say for folks who aren't in the medical field is that the biggest motivator in all of this is patients asking about it and being concerned about their health and asking informed questions about their health. So I have some patients who are just so into or involved in understanding what the latest research is, understanding how these exposures affect their health, and it's such a pleasure to work with them to try to figure out a way to make them and their families healthier. These are a few of the resources that I mentioned. Some of them are these two, the NASEM report and the JAMA viewpoint, are both pretty clinical. Those are things that you could certainly share with your doctor. And what I'll say is the NASEM report is a 6-page summary, which is much more accessible. This organization, PFAS Reach, is hosted with the Silent Spring Institute in Massachusetts. And the PFAS Reach project has some really wonderful resources for patients about understanding exposure and how to approach your doctor, and as well as for clinicians that you could share with your doctor. And of course, I'm happy to always answer questions. So that's my email right there. Thank you so much.
Thank you so much, Dr. Criswell. So next up, Maya Ramwat, our Director of Campaigns and Programs, is going to help moderate us to make sure that we address some of the questions that have come up. So thank you all for speaking, and thank you all for the questions you've been submitting. Maya, take it away.
Hi, everyone. Welcome. Just in case you're curious about those slides, we will be sending those out in our follow-up email. First question is from Darius to Kristina. How do we measure cancer prevention funding? Does money spent, for instance, on catalytic converters and smokestack scrubbers count? And if not, are we underestimating?
It's really hard to pin down numbers on this. This was something I dug to find when I was working on the book, and I could really only find one study that had made an attempt to estimate how much global cancer research funding was directed toward prevention, and that's where that 7 to 9% figure came. So if we were to count things like money spent on reducing pollution, we definitely could broaden that category. I also think it'd be really helpful to have better, more concrete, more up-to-date numbers on that in general. But yeah, the answer is it's really tough to track down that data.
Thank you. And then a question to Dr. Criswell from David. What are the cumulative effects on human health from PFAS, methyl mercury, PCBs, et cetera?
Thanks so much for that question. So my research is mostly into PFAS. I'd have to look up methyl mercury and PCBs, but there's a good body of evidence for each of these chemical classes about what the typical health outcomes are. I just refer you back to the NASEM report for PFAS. The strongly associated health outcomes are decreased antibody response, so immune system dysfunction, sort of colloquially, kidney cancer, and dyslipidemia or cholesterol changes.
Thank you. And then a question from Julie to Emily. To create critical mass action, are you reaching out to like-minded organizations, environmental health associations, for instance, for coalition building, for example, state and local health associations, state green amendments initiative, things like that?
Yeah, so organizations like Defend Our Health, a lot of us are state-based organizations that participate in national efforts and collaborate with our partners in other states. So Defend Our Health, we're based in Maine, as I said at the top. But we do a majority of our like organizing and policy work in Maine. A lot of our campaigning is more nationally focused, and we participate in networks like Safer States. We do work with organizations that are based in other states plus national networks. I think especially at the time that we're in right now, federal policy is great. The federal agencies that are supposed to take action on these chemicals, that is the most efficient way from like a market change perspective to really regulate these chemicals. But the federal agencies have lagged in regulating microplastics, in regulating food additives that are petroleum based, in regulating PFAS in consumer goods and food systems. So state action is really one of the places where we've been able to advance safety and improve regulation of these chemicals effectively. Maine has put in place sludge spreading bans for our farms that we are then helping other states to consider mirroring. We have put in place drinking water standards. We have put in place a product phase out. So most consumer goods are not going to be permitted to have PFAS as a class in Maine. And there are several other states that are either working on or implementing similar phase outs and bans. And that type of consumer action and state level action is changing the products that are being sold nationally, not just in the individual states those policies are passed in.
Thanks. Do you want to follow up, Emily, and describe, you mentioned regulating as a class. Do you want to say more about that?
Yeah, sure. So PFAS is a really good example of this because PFAS is kind of the top line name for a group of chemicals that are all very chemically similar. They have one or more fluorinated bonds. But there are somewhere between 13 and 15,000 chemicals in the class of PFAS that are all individually molecularly distinct. And the way that the federal government regulates chemicals right now is individual chemical by individual chemical. A good example of this is not PFAS, but another example would be you've surely seen things that say this is BPA free. And so we know from evidence that BPA is a potent and toxic chemical that should not be in contact with especially children's food and children's products. BPA free, BPA is a single type of bisphenol. There are multiple other bisphenols that are very chemically similar. So when BPAs were being banned in various products, most companies, they didn't stop using a bisphenol. They switched from BPA to BPS or another bisphenol. And so they have something which is functionally similar in their product now, providing the same sort of can liner or other function, but it's got very similar health concerns. It just hasn't been regulated. So regulating as a class and saying we're going to ban bisphenols or we're going to ban PFAS from being in certain product categories is much more effective because it says, industry, you have to stop experimenting on us with new versions of these chemicals. You have to find a safer solution.
Thank you. And then I'm not sure if anyone can answer this question, but from Syed, if anyone knows, are PFAS being used in water desalination plants, for instance, like those that are being considered in Texas and California?
I don't know the answer to that directly, but I do know that PFAS are used pretty regularly in the fracking industry. There are some good reports that have come out in the last couple of years documenting that their use in hydraulic fracturing is pretty widespread and kind of scantily documented. So we don't have a good sense of how prevalent that is. And then a lot of times those desalination plants are taking salty water that is a byproduct of hydraulic fracturing. So I don't know that they're using PFAS in the process, but I would guess that it's possible that PFAS are finding their way there.
Yeah, and that's been going on because companies are allowed to have not disclose the myriad chemicals that are used in that process because it's considered proprietary. We've got another question for Dr. Criswell. You described the tests for PFAS and blood levels and mentioned that almost 90% of us are in the middle risk category. Is it possible for any of us to walk into our doctor's office if obviously if you were our doctor, perhaps, and get a PFAS test of our blood, or do we need to be considered the highest risk exposure for that to happen, or is it even more complicated?
That's a really great question. The recommendation from the National Academies right now is that we test people at risk of high levels of exposure because that would change our approach to care. And so a lot of, well, let me back up. This is not something that we typically learn about in med school, and it's not something that insurers typically cover. So some of the barriers I've heard from that patients experience is that doctors aren't familiar with PFAS testing or how to interpret. And then another barrier is that if you do get the test ordered, sometimes your insurance won't cover it. Maine is kind of an interesting test case because we are having a lot of legislative action around PFAS. And so one of the things that Defend Our Health in particular has been working on is trying to understand who should PFAS testing be covered for if insurers are going to cover it. And the group that seems to be the most obvious is this group of high-risk folks that are spelled out in that National Academies of Science. So I think as a physician, I wouldn't recommend blood testing unless you are in one of those high risk groups, again, because it wouldn't change your approach to care or the preventive care that you would receive. And I think it's totally reasonable to talk through your exposures with your physician, knowing that you may have to bring some of these resources to them and review them together so that they understand where you're coming from.
Thank you. One for Kristina. Can you say more about the 5 chemicals you mentioned that were removed from the market due to safety and how that history may be informative to us now?
I can try. I don't know what they are off the top of my head. We're in a weird place right now. Those 5 chemicals I'm referring to are ones that were banned, by EPA or FDA. As folks know, we're in a weird era right now of like some interest in banning harmful chemicals from food and products, but a lot of kind of non-science that's involved in those conversations with RFK Jr. I think one really important takeaway, and I wanted to say this too based on some of the other questions and comments I saw go by, is that states have really stepped up recently in the absence of meaningful federal regulations on toxic chemicals and particularly PFAS. There's this great website I can put in the chat. You mentioned Safer States, Emily, but they have a really helpful tracker. They say 35 states have introduced 206 policies related to PFAS. And one cool thing that happens with state policies, someone also mentioned, like, isn't it kind of not useful to contact regulators right now? But there's a lot we can do at the state and local levels. And for state level regulations, when a state bans a chemical in a consumer product, it's really a pain for manufacturers to make a different version of their product for that one state. So they tend to just change the formula across the board. So state level regulations are often standing in for federal regulations when it comes to toxic chemical exposures. So I would say there's a lot of good stuff happening at the state level, and that's a really effective place to kind of push on these levers at this time.
Thank you. And that's it for our questions, and it's perfect timing. We're running out of time, so I'll pass it back to you, Emily.
All right. Thank you so much, everyone, for being here. I know that there are more things that are coming in the Q&A, and we are very happy to continue the conversation with everyone. This is such an important issue. Cancer is a chronic disease that is both genetic and individual action, and also these larger environmental exposures. And there are so many other health outcomes that are happening that are harms that are happening because of these larger environmental exposures. We as individuals, we can do what we can, but as Kristina said, we cannot shop our way out of this. It is really, really challenging and nigh on impossible to protect yourself and your family from these chemical exposures and the harms that they cause on your own. So I urge you, whether it's joining in the actions that Defend is pushing for, whether it is joining other community and state level groups, is really come together as communities and work to push for these changes. We need these state policies in place. We need corporations to stop producing and stop using these chemicals. And we need to use our market power and our political power and our watching, our keeping an eye on these things and letting them not get away with poisoning our kids. So I really appreciate the time that you've come to join us today. I hope that you read Kristina's book. I hope that you have a fantastic and healthy and safe summer. We're going to be having a series of these author and friends talks for the rest of the year. So you're on our list now. You will get the notification. And for the couple of you who had typos in your emails, I'll make sure that we've got you corrected so that you get the messages going forward. But I thank you so much for joining us. Really, together, collectively, we can protect our families and our communities from these toxics. And I'm really excited to do it with you all today.
Oh, and
and going
Emily,
forward. Yes,
real
thank
quick,
you.
do we
Sorry.
have a book code to share?
I don't actually have the book code in front of me, but we will be emailing it out with the recording of this session. Apologies, I unrecorded us at the very beginning, so we're missing like the first 2 minutes of this in the recording, but really appreciate all of your time, and you will get a book code from us within the next 24 to 36 hours via email.
I believe it's webinar. I think you can use the code
Ooh.
webinar for 30% off when you buy through the publisher, which is Island Press.
Thank you, Kristina. Thank you, Kristina. Thank you, Dr. Criswell. Thank you, Maya. Thank you, Taylor. Thank you, everyone who's joined us today.
Thank you.
Everybody.